Thank you very much. Uh, I appreciate the opportunity. I sat through Deborah's talk, and I am just so impressed that we have people who really understand the level of detail that supports our rural hospitals. I'm originally from Oklahoma. I was born on the Muskogee Creek Indian Reservation because there was not a hospital in my little town. I think they have one now, but in 1948, after World War II, they didn't have it. So I've always had a focus on rural health. I've always had a focus on the issues of healthcare in rural communities. I think this is a wonderful opportunity for people like yourselves to get together and discuss these things. I wholeheartedly agree that rural hospitals should be exempted from these cuts, especially during this pandemic. I think it's unfair to look at this as business as usual. I'm also a little upset that we have been asked to curtail elective procedures. I think that's probably unnecessary, especially for rural hospitals. That might be something that some of the large medical centers should kind of look at, but not for rural hospitals. They don't have that capacity to take care of that many COVID patients. So I think rural hospitals, in my opinion, have always had to share a little bit more of the burden than some of the more urban hospitals. But I think we all know how important those rural hospitals are to us. Let me back up. Am I on a timer here?
Let's see.
Anyway, I wanted to share with you a little bit of some graphics that show where some of our rural hospitals are. I don't know if you can see the colors that well, but the blues are critical access hospitals. And you can see that they're fairly well distributed around the state. There is a little bit of a concentration in the eastern part. And then the rural health clinics have a tendency, I think, to sort of follow those, and they are in the green. Sometimes it's a little hard to discern the difference, but if you can see a lot of the blue dots, there's also green nearby. But the federally qualified health centers are in brown, and they really have a tendency to cluster in sort of the middle of the state. And if you look down in the southeast, you can see a large cluster of federally qualified health centers. You can also see where the large urban areas are, and you can see some of the things that are kind of clustered around there. But I also wanted to look at the same state and remember what the distribution of rural health and critical access hospitals were, and now look at the distribution of primary care physicians. There are states that don't have any physicians at all. There's 35 of them. And there are states that have 5 or fewer, and you can see the color distribution. But you can also see where the large concentrations of physicians are in Houston, and then you go straight west, and that's San Antonio, and you follow I-35 right up, and there's I'm sorry, this must be on a timer. I didn't do that. Anyway, so you can see the distribution of hospital primary care physicians. A lot of them are in the east of I-35. And we know that there's a mismatch between the physicians and patients and access to care. Western counties do have fewer physicians, but there's also fewer patients. This has been a change over time. 20 years ago, 14 of the states, 254 counties had no doctors, and that's jumped up to 33 now. There's been a problem with closure. Rural hospitals, 26 of our rural hospitals have closed since 2010. There was 300 rural hospitals in the 60s, and now it's down to 158. This is 2018 data. That just closures are driven a lot by Medicare cuts, as we've already heard Deborah talk about. And there's been a $80+ billion a year underpayment Texas Medicaid. I sit on the hospital board of our community hospital in Huntsville Memorial, and so I get to see some of the logistics of the underpayment that we get, especially because we have a very active emergency room there, and they have to see everyone. And a significant portion of that care is not paid for. These closures have a ripple effect. We saw that in communities around Huntsville. And the fact is that there's few businesses who are willing to relocate to a community where they don't have appropriate health care. They don't have a hospital. They don't have the right mix of physicians, and it becomes problematic. Oh, what am I doing here?
Go down. Exhale.
Here?
Yes.
Yeah. And then I'm going to advance.
Yes.
How do I advance the slides?
Wait. The other one.
All right, now we got it. So it looks like I'm new to this, but I've been doing this for 40 years. We talk a lot about the social determinants of health. And, you know, we talk about looking at the eastern part of Texas, and especially in the rural communities. Part of the issues are lack of insurance, poverty, and education. A significant number of people don't actually finish high school. There's a larger unemployment rate in eastern Texas and in rural communities, and access to certain specialties like pediatrics is very limited. But I would throw in mental health as a #1 issue in rural communities as well. So some of the specialties that I think we really have trouble with are general surgery, mental health, and primary care. This is the data source for this, the Kaiser Family Foundation.
Move on to the slide.
Here, I'm going to let you do it. Get my slide changer here. Well, as the Dean of College of Medicine, you know, we want to talk a little bit about what can we do to kind of help mitigate some of these issues in Eastern Texas. I actually was in Indiana as the clinical dean of a brand new medical school there when I was asked to come and interview for this program. Indiana program, that was a private institution. Sam Houston, of course, is a state university medical school. We have a sign by Governor Abbott that makes us a official Texas State Medical School. But we have a lot of issues that we have to deal with in terms of making sure that we agree with the university and with the regents and with the politics of the state. And so we're very careful about these things, but we need to be able to be engaged with the community, engaged with schools and with political venues, because we need to be able to recruit from that area so that we can get people back to that area. But some of the things that have happened politically, and I think Deborah probably alluded to this, is several reductions in payments to rural hospitals. And It would be nice if the state could go ahead and expand Medicaid through the Affordable Care Act. We'd get extended coverage to several, 1.4 million uninsured Texans. And it would also provide much needed revenue for hospitals. I think they may be going to do that in the next session, but you never know. There's also talk about having a community tax, that helps keep hospitals open. I think part of the property tax, I think, in our county helps go to the hospital. We have freestanding emergency rooms in our area. If you go there, you get a huge bill because it's emergency medicine. But what they actually do is basically urgent care. I think we need more freestanding urgent care centers and less freestanding emergency rooms. We also need physician partners. One of the biggest problems we had in Indiana was we'd lose practitioners because they were in solo practice and they couldn't get away. They couldn't go to a meeting to get CME. They couldn't go on vacation. And they couldn't get partners. And that was a big problem for them. So we had developed a program of locum tenens where we could help identify ahead of time people who needed coverage and arrange that for them through a local agency. And we also are invested in developing new residency programs at East Texas in some of our regional hospitals. And this is really important to the hospitals themselves because they see it as a way to recruit new partners in the future. So if they can bring students in to do their residency, there's a real good chance that that person might stay there after their residency and so why a college of osteopathic medicine? I graduated from medical school in 1977 and finished my residency in 1980. I've been practicing for over 36 years, and I've been in academic medicine for about, I started in 2000, whatever. But I'm an osteopathic physician. And so one of the advantages of looking at osteopathic medicine is that we are very well aligned with the mission of the university. The university for 100 years has been focusing on East Texas. We have a lot of graduates from this university that are in East Texas. Many of them are in the school system. And we have a history in osteopathic medicine of our graduates going into primary care. You can see the numbers there. But we have a focus in this university on clinical education and communities. We also have a very nice research agenda also, and we have 4 NIH investigators on our faculty. But our main goal is to develop people who are interested in primary care. This is the mission statement of our university, and I wrote this. I believe in it. I believe in East Texas, and I believe that we can make a difference. I've been licensed in Texas since 1997, but I was in San Antonio most of the time, and so being in this part of the state is a little bit new to me, but I have embraced it after coming here and seeing the work that the university was doing. We really have a goal of trying to change the medical workforce in East Texas, and I'll talk a little bit about how we're going to do that. One of the things that I talked about just a minute ago that's very important, it's important to us from a practical standpoint of how we want to help the access to care in East Texas, but also as part of our accreditation, we need to be able to do this. So we have spent a lot of time talking with our hospital partners and places like Nacogdoches and Lufkin and Christus hospitals, St. Elizabeth's and Baptist, and down in the Southeast Hospital. There's a lot of interest out there in looking at how they can develop GME in their hospitals as a way to attract a higher academic standing and get partners from our graduating class. So we actually have a plan to recruit students from that service area of East Texas with the idea that they'll be more likely to return there for GME, graduate medical education, and then to practice. This is something that's not new to us. The Graham Center has done a lot of research in this area, and this is the one thing that they point to over and over again in terms of recruiting students, in terms of where they would likely to be placed after they finish. They even go down to the level of where did they go to high school, things like that. We actually are also going to develop our own pipeline program, and we will be recruiting from high schools. And we have a lot of connections through our admissions office here at the university and advisors in the different high schools in East Texas. There are also some very nice foundations in this area, like the Temple Foundation, the Meadows Foundation. And the Temple Foundation has been funding the graduate medical education development in Lufkin, and they're wanting to bring in internal medicine and psychiatry. The coordinating board of Texas has also given Baptist Hospital about $250,000 to help support their development of graduate medical education. And they tell me that they will be ready to go into the match this fall to have residents start in 2021. We also have some plans to develop some programs in East Texas that have to do with community engagement. We have done a lot of work in this area in the past in other states, but what we're really wanting to do is to use, this is a statement from the Kellogg Foundation about community-based participatory research. And it's really a method of bringing community partners together to do needs assessments, look at what their problems are, and then to have people in the university look at developing programs that can look at having outcomes that are measurable, and so we can actually see that they've achieved some success in doing some interventions. The model for this is pretty straightforward. It looks like there's a lot there, but it's really basically that community looking at or being willing to look at some of the issues that they have in their community, and these partners can come from a variety of places. We've partnered with the mayor's office sometimes, or a faith-based institution and churches, and we've used the housing authority sometimes, but we're looking for areas that are meaningful in that community, that we can have some intervention that would create a lasting effect. And so we asked them to help us with the needs assessment. We passed that information on to our researchers and look at developing the metrics from the needs assessment, and then they can oftentimes look at this as a policy. This is just this PICO thing is just a way to look at how to develop your ideas for developing an intervention. So basically, this is a little, just a figure that shows what the model kind of looks like, the two parts. The one is community engagement, and the other part is looking at an assessment of outcomes for an intervention. We have a lot of interest in this. It's just not the medical school that's interested. The entire university is looking at this. We have an office of community engagement at the university, and we have a research center, and the ORSP, they're able to look at how to get funding for projects just like this. And so this is something that we anticipate ramping up and going into these communities with a lot of energy and a lot of willingness to stay with it and help them create opportunities. And I think this, plus bringing people back into our medical school from that particular area, and then also taking them back into the community for graduate medical education and then practice, I think it's going to be a good solution. It's going to take a long time. You know, medical school's 4 years, residency's 3 years. So you have to look down the road. I wanted to conclude this just by some things that put together. My family doctor, when I told him I was going to go to medical school, I sat down and he said, these are the things I want you to remember. Always be proactive in your community. Go and speak to the classes in the high school about drug use, prevention, smoking, whatever. Volunteer to be in the sports team. This guy walked the lines of the football games every Friday night. He helped in the training room and all kinds of stuff. And he said, always spend money in the community. If you want to buy a car in your community. Don't be seen spending money away from the community. Become part of the social makeup of the community. My family doctor was on the school board, and he was a leader in the community. The one thing he kind of told me a little bit tongue in cheek, because he had terrible hours. He probably worked 90 to 100 hours a week. He said, always go to church every Sunday. It'll be the best rest you'll ever get. So those are the things that they're not anecdotal. I think about him every once in a while, and I think about him, and I think about his dedication to our small town. I think there were only 2 doctors in our community when I grew up there. But you know, these are the kind of people that are the bedrock of our rural communities. They've stayed there, they've lived there, they've been part of it in the good times and bad times. They are the go-to people. So we'd like to help create that problem for you and bring a lot more people into the community and populate the rural health centers. And I think we can do that. It's going to take time, but we've got a really good class right now that we're getting ready to start with. And a little over half of that class came from East Texas, from our area of focus. So I'm optimistic that we're going to create some good positive outcomes. That's I'll turn it over to questions.
Okay, any questions? Doctor, we hope some of those physicians will come out to West Texas too.
Well, we do. We have some people who came from West Texas. And I have good friends who are in that area. But I wanted us to be truly be the 8th college of the university. And that meant that we really needed to embrace the vision of the institution. And they are heavily focused on East Texas. They have made large investments in time and effort. And a lot of their graduates are still working in Eastern Texas. So I felt like we really owed that to the university. there are places around us that are pretty wealthy. We're not that far from the Woodlands and hospitals there, but they don't really need us. East Texas needs us, and I think it's fairly compelling that we need them, and we need to be able to be part of that community and be a positive effect. The hospitals there are very good. The large regional hospitals, they see a lot of patients. Our medical students are going to rotate through those hospitals, and they'll be working with residents in our graduate medical education programs in those hospitals. So I think that's gonna, over time, that will definitely make a difference.
Well, and a lot of people don't appreciate how rural East Texas can actually be. I really didn't appreciate it until I was working with the hospital in Hemphill and St. Augustine in that area. And those are extremely isolated areas with very remote, very rural populations.
We have some other, I don't know that I know the name of the hospital in St. Augustine, but we have a lot of other rural hospitals. We're not just looking at the regional medical centers. We also look at several of the smaller community hospitals, and we have rural rotations for our medical students through several of them. And I've enjoyed going there because every time I go and talk to the leadership of some of the community hospitals, I walk away with a really good feeling about what they're doing there in the community. And they're very excited about our working with them. So I think I can afford to be a little bit optimistic. We've worked hard, to get to where we are now. We have a level of accreditation from our national accreditors that allows us to recruit students and to do all the things that we're doing right now. And the only level of accreditation that's left to us is full accreditation, and that won't happen really until we graduate a class. So we are able to do everything right now that we would normally do if we had full accreditation. But we just need to go ahead and train our students and get ready for the qualifying exams and also for their residency programs. So it's building, and we're just starting. So what we have right now, we'll be able to leverage this quite a bit in the next few years.
Well, we appreciate the opportunity to be with you here at the beginning stages, and we look forward to a long, successful operation.
Well, you're very nice to say that. I appreciate it.
Okay. Are there any other questions? Okay, well, we're going to go ahead and wind up a little bit early. We'll have the same time next week. We have the 2 sessions. One will be developing a telecardiology program by Dr. Chris Gallagher. He's with Access Physicians, if you want to do a little study ahead of time. And then we also have a presentation from Christopher Collins and Sophie Novak. They are writers for the Texas Observer. They recently wrote a series of articles on critical condition of rural hospitals, especially in West Texas. And if you haven't had a chance to read that, you might want to go to Texas Observer and look it up. It's a very interesting piece of work they've done, and they're going to kind of explain their methodology and some of the things that they saw. So I'll open up one last time to the chat line if there are any final questions or comments or observations.
The opportunity to be here.
Well, Doctor, we appreciate your time. Deborah, we appreciate your time. And so I guess we'll see you all next week. Thanks.